Hello, friends. Let's continue today about the hypertensive disorders of pregnancy. Yesterday, I dealt in detail about the pathogenesis, and towards the end, abruptly, the time was over. So today, let me recapitulate where I left yesterday, and that is the pathogenesis conclusion that we have drawn. We can safely say preeclampsia is a systemic disease of maternal endothelial cell dysfunction. After all, that's what it happens, even though it starts in the very early pregnancy in the form of reduced placental perfusion. In the second half of pregnancy, the maternal syndrome is because of endothelial cell dysfunction. So the pathogenesis and pathophysiology can be summarized in this flow chart as it has a genetic origin, also affected by immunological reasons and pro-inflammatory factors. Altogether, there is faulty placentation. Placenta is the main culprit, and that is, it has got inadequate trophoblastic invasion, and that's why there is reduced placental perfusion. So this reduced placental perfusion is the root cause of all the manifestations of preeclampsia in the presence of inflammatory process due to oxidative stress. There is endothelial dysfunction. That is the connection. Now, this endothelial dysfunction will give rise to vasospasm. That is the cause of hypertension, oliguria because of reduced renal blood flow, abruption, and seizure because of hemorrhage or edema in the brain. There is capillary leak because of endothelial dysfunction, and that is the cause of edema and pulmonary edema, proteinuria, and headache. Of course, that leakage leading on to the brain hemorrhage also can give rise to blurring of vision if it is in the optic chiasmal region, and there is epigastric pain. And this is not due to gastritis. This is due to subcapsular hemorrhage of the liver. The other thing that happens in the endothelial dysfunction is coagulation problems, which will lead to thrombocytopenia, hemorrhage, and DIC. So all the manifestations of preeclampsia can be connected to endothelial dysfunction, which is because of reduced uteroplacental perfusion in the presence of inflammatory process due to oxidative stress. This is an important slide. You can take a screenshot of this slide. Of course, if you take it backwards, the vasospasm as well as coagulation that can lead you to the vasoactive agents, that is nitric oxide, endothelins, and cytokines and lipid peroxidases, which in turn will reduce the uteroplacental perfusion. So it is a perfect vicious circle. So now I come to pathophysiology of preeclampsia. What happens in CVS, cardiovascular system? There is increased cardiac afterload because of the problems in the vasculature system itself, increased left ventricular mass, and increased left-sided filling pressures, and extravasation into extracellular space, especially lungs. What happens in the hematological system? There is hemoconcentration because of leak of the fluid from the intravascular compartment. There is hypovolemia. That's exactly why we don't give diuretics in preeclampsia. As I said other day, there will be a situation of poverty amongst plenty. There's plenty of fluid in the body, but in the wrong place. It's something like during flood, we say, water, water everywhere, but there's no drinking water. thrombocytopenia, and there is intravascular coagulation. I have already explained this. And erythrocyte destruction, hemolysis, which is the cause of HELP syndrome. In endocrinology, there is reduced renin, angiotensin 2, and aldosterone. There is increased deoxycorticosterone, that is the cause of sodium retention. Normal vasopressin. As far as fluid and electrolytes, there is expanded extracellular fluid. We all know that. Electrolyte concentrations not disturbed much though. There is decreased pH and bicarbonates following eclamptic convulsions. There is hyperventilation. In kidneys, there is renal perfusion and decrease in GFR. Serum creatinine and uric acid is increased. That's one of the hallmarks. Decreased urinary calcium, if at all you do that. Proteinuria, very well-known fact. In liver, periportal hemorrhage, increased transaminase levels, one of the diagnostic points of preeclampsia. Hepatic rupture, this can be one of the causes of death. In fact, I remember very well the article written by Sibai, who is an authority on preeclampsia in their center. They, in fact, missed out on the pain abdomen, and they thought it could be gastritis. And actually, it was a case of HELP syndrome leading on to hepatic rupture, subcapsular hemorrhage, and hepatic rupture. And they lost the patient long ago. In brain, again, there are different changes. Type 1 changes. One is hemorrhage. Type 2 changes is edema and hyperemia, ischemia, and thrombosis. So in other words, almost all the organs in the body are involved because of the single factor, that is vasospasm, and if at all, another factor, that is vascular occlusion, which lead to endothelial dysfunction, explaining and deserving the name that is given to preeclampsia as a multi-system, multi-organ disorder. So in eclampsia, what happens? There is transient loss of cerebrovascular autoregulation because of brain edema or hemorrhage or both. There is hyperperfusion as seen in hypertensive encephalopathy. And in uteroplacental bed, there is reduced placental perfusion. Uterine artery Doppler indices are increased, which are one of the predictors. So I can re-summarize entire yesterday's class before I go on to today's class as preeclampsia is a systemic disease of maternal endothelial dysfunction. I'm repeating very many times so that just by listening to what I'm saying, you can just remember that. It's a systemic disease of maternal endothelial dysfunction resulting from a deficient endovascular invasion of fetal extravillous cytotrophoblast into the maternal spiral arterioles, a process facilitated by cytokines and angiogenic factor producing uterine and decidual CD56 bright NK cells and impeded by CD56 dim NK cells. Yesterday I was talking about two different types of natural killer cells. The dim cells are cytotoxic and the other ones are friendly. It's a unique variant of immune maladaptation at the level of feto-maternal interface in susceptible persons caused by mixture of insufficient maternal tolerance to paternal antigens. That is exactly why the first pregnancy with a change of partner or with the same partner who has used condom for a long time, every time it is something like a exposure to new paternal antigens and insufficient maternal tolerance is the problem. And unfavorable combinations of genetically determined maternal leukocytes and fetal antigens. I was talking about yesterday genetic factors and HLA types. So that is the total recipe for preeclampsia. So I can conclude this part of the talk by giving you the final unifying theory, that is maternal factors, namely genetics, pro-inflammatory and immune-mediated. And in stage 1, there is reduced placental perfusion as a result of these maternal factors. These are the factors which determine the absence of invasion of the vascular intima by the cytotrophoblast. Net result in endothelial dysfunction in the presence of oxidative stress. So the first one is called stage 1, other one is called stage 2, leading to preeclampsia. I hope it's amply clear now, and you can write a beautiful answer about the pathophysiology of preeclampsia. Let's move on to the prediction. This has actually interested many researchers and scientists, because only when you predict can you tackle this perfectly or prevent it. The tragedy is that, as I said, till today, as I'm speaking today, that is 9th November 2022, nobody knows the exact triggering factor. That's why there are lots and lots of predictive tests that have been tested. So let's go through them. Early pregnancy prediction of preeclampsia in 2020, we are left with only risk factors, not exact predictive factors. What are these risk factors? Nulliparity, a very well known, right from my undergraduate days, 1980s. Preeclampsia in a previous pregnancy of the same lady. As I told you yesterday, there is 25% recurrence in a lady, even with the same husband. Age less than 18 and more than 40, extremes of age group is a risk factor. More than 40, we can easily understand that generally she is prone for hypertensive diseases, but very young age, probably her immune system is not ready to accept a foreign antigen. After all, preeclampsia is a maladaptation of the immunological system. Family history of preeclampsia, mother having preeclampsia, the daughter also can have preeclampsia. Chronic hypertension, we all have already seen in the classification of preeclampsia. Preeclampsia can be superimposed on a lady who is more prone for chronic hypertension because there is a dyslipidemia syndrome in the person. And whenever there is dyslipidemia, the things that you get free are diabetes, hypertension, preeclampsia, and all other problems. Chronic renal disease, we all have seen how closely preeclampsia is related to renin-angiotensin system. And should there be chronic renal disease, she is more prone for preeclampsia. Some more risk factors: autoimmune disease like antiphospholipid syndrome, systemic lupus erythematosus. This is one of the clinical indicators of APLA syndrome. We all know in APLA we have got clinical indicators and the lab indicators. Preeclampsia, preterm labor, FGR, these are the clinical indicators, including abortions. Vascular disease. Since yesterday, I have been telling that preeclampsia is a vascular disease. There is vasospasm, vascular occlusion, endothelial dysfunction. So those who are more prone for vascular disease should automatically develop preeclampsia. Diabetes, both pre-gestational and gestational. Just now in the previous slide, I said, diabetes, hypertension, preeclampsia are all close friends, cousins, siblings, whatever you want to call. Obesity. Yes, obesity leads to diabetes. And these are the patients who have got the perfect backdrop to develop hypertension and preeclampsia. Multifetal gestation. After all, placenta is the disease or problem of the preeclampsia is a problem of placenta, and in multifetal gestation, there's plenty of placenta. Hydrops vitalis. These are the patients who have got different problems, maladaptation problems, non-immune and immune hydrops, and poorly controlled hyperthyroidism. This is also a risk factor. More, woman herself was small for gestational age when she was in her mother's womb, which again means there is a genetic factor involved. FGR, abruptio placenta or fetal demise in a previous pregnancy, which means that she must have had previous pregnancy preeclampsia, which recurs. Interpregnancy interval increases the risk. This we know. As I told you yesterday, if you prolong the interval between the pregnancies, especially using condoms, next time when you become pregnant, the same sperms of her same husband will be considered like a foreign antigen and it will be not tolerated well. Long interval, if previous pregnancy was normotensive. If the short interval, if the previous pregnancy was preeclamptic. So if the previous pregnancy was normotensive, then you require a longer interval. But if the previous pregnancy was preeclamptic, even a shorter interval will give rise to preeclampsia. Partner-related factors. This I have amply explained yesterday, but again, just to summarize, newer partner, limited sperm exposure, that means previous use of barrier contraceptives. So all these are risk factors. IVF pregnancy, as it is, IVF patients are probably mostly PCOS patients who have got insulin resistance, and that itself means they are more prone for type 2 diabetes, hypertension in life. Also, the type of factors that are involved in IVF, the treatment part of it, everything will give rise to preeclampsia. Obstructive sleep apnea, elevated blood lead levels, post-traumatic stress disorder, and black race. These are some of the other risk factors. Now, all these risk factors have been repackaged by United States Preventive Services Task Force as high risk. Among the risk factors, some of them are very high risk, some of them are moderate risk, and some of them are just risk factors. What are the high risk factors? Among the bigger list, 4-slide list I gave you, the high risk factors are previous pregnancy with preeclampsia, especially early onset and with an adverse outcome. So the same lady, she is gravida too, but in the previous pregnancy, she had a preeclampsia, that too early onset preeclampsia before 34 weeks, and that ended up with eclampsia or any other adverse outcome. This lady is more at risk for developing preeclampsia again. She comes within that 25%. Multifetal gestation is a very high risk factor for preeclampsia. Chronic hypertension, very easily understandable. Type 1 and 2 diabetes mellitus, again, the part of dyslipidemia syndrome. Renal disease, very clear, easy. Autoimmune disease, that is antiphospholipid syndrome and systemic lupus erythematosus. These are very high risk for preeclampsia. Who are moderate risk? Nulliparity or primiparity, obesity, body mass index more than 30 kgs per meter square, family history of preeclampsia in mother or sister. See, in the high risk we saw she herself had preeclampsia. Easy for us to remember. In moderate risk, she didn't have, but family history is there. Age more than 35. So it's something like indirect. Instead of saying directly having hypertension herself, age more than 35, which is more risky for having hypertension. Socio-demographic characteristics like African race, low socioeconomic levels, and personal risk factors like history of low birth weight or small for gestation herself previous adverse pregnancy outcomes, anything, not just preeclampsia, or more than 10-year pregnancy interval, which again explains that no exposure to sperms for a long time. So now let us look at the tests, predictive tests that have been done. I am not going to tell all the tests, especially the tests which have been now discarded. These tests are, as prescribed, a prediction of preeclampsia, review of reviews, ultrasound, obstetrics and gynecology, 2019 published one. Also, those suggested by United States Preventive Services Task Force and WHO in 2004. Systematic reviews of studies that evaluated clinical tests, available tests, have generally concluded that these tests are not sufficiently accurate. The clinical tests, may it is rollover test or grip test or whatever it is, they are not sufficiently accurate means they do not have high sensitivity and high specificity for screening the general obstetric population. So whenever you screen, you have to screen general population. High-risk population is different. In high-risk population, probably these clinical tests give you good results, good predictions. But when you say screening, it has to be done in a general population. That means in every single lady. They are not good enough. They are not highly sensitive and specific. The overall methodologic quality of available studies was generally poor. This is the conclusion of all the tests together. Now, ACOG practice bulletin in 2020, let's see what they suggested. Going back to roots. It's like old fashions come back as new fashion. After all those tests over all those years, we are going back to the basics. That is, take a detailed medical history and assess blood pressure to evaluate a patient's risk for developing preeclampsia. This may sound like ancient, but that's the recent advance. Old fashion coming back as a new fashion. History taking and taking blood pressure. As simple as that. What are the biomarkers to sound posh? These are all 2010 and 2007. The previous slide was 2020. The angiogenic factors, I was talking about them yesterday. Vascular endothelial growth factor, VEGF. Placental growth factor, PLGF. Anti-angiogenic proteins, soluble endoglin, SENG, and soluble FMS like tyrosine kinase 1, SFLT1. So these factors are called the biomarkers for preeclampsia. You can either evaluate them alone or you can evaluate them along with other tests. Nowadays, we test them along with the dual test that we do for Down syndrome, and we get a risk factor. I'm going to explain that further in next slides. In women who developed preeclampsia, concentrations of placental growth factor, PLGF, and VEGF, vascular endothelial growth factor, were lower. Concentrations of anti-angiogenic factors, that is SFLT1 and SENG, soluble endoglin, were higher. So this is the general idea that we must have. Other lab tests, increasing evidence suggests that unexplained abnormal maternal serum analyte concentrations in the first and second trimester predict development of preeclampsia. Pregnancy-associated plasma protein A, PAP-A, which we always do in the dual test. That's what I was trying to tell you. These also some sort of prediction for preeclampsia, FGR, other than Down syndrome. Abnormalities in cell-free DNA levels. Again, like we try to predict the Down syndrome by testing the cell-free DNA levels. Uterine artery Doppler, way back in probably 90s, I gave 2 of my PG students thesis on this, uterine artery Doppler. Although meta-analysis show that uterine artery Doppler analysis can predict women at increased risk of preeclampsia, most experts do not recommend these studies for screening in early pregnancy, as false positive rate of this test is quite high, leading to excessive patient anxiety and healthcare costs. We found in our study, if I remember correctly, the sensitivity was less than 60%. Specificity was not great. I don't exactly remember, but it was not great. So this is the final opinion about uterine artery Doppler. Then ophthalmic artery Doppler. People have tried every single artery that is amenable for Dopplering. Ophthalmic artery Doppler velocimetry has also been used to predict development of preeclampsia, because this is one artery which you can easily find out. Similar to Doppler studies of uterine arteries, ophthalmic artery Doppler velocimetry likely has little clinical utility as a standalone predictive test for either early or late onset preeclampsia. All of them, what story they are telling us is that you cannot depend upon a single test. You probably can rely nowadays mostly on the history, the risk factors that I listed, and probably the actual taking of the blood pressure. If you want, you can use mean arterial pressure, as I was telling yesterday while talking about the definitions. And then to that, if you add these biomarkers and then the Dopplers and combined scoring, if you do, probably that is better. So risk prediction modules or modes. Detection rates of fetal maternal foundation, London, and fetal medicine, Barcelona, combined first trimester screening algorithms for prediction of preterm preeclampsia range from 75 to 92% at a false positive rate of only 10%. This is published in Hypertension Pregnancy in 2020. So that's what I was trying to tell you. We can combine the first trimester screening algorithms. Anyway, now in most of the centers, at least in Manipal, it's a routine. Every single lady that comes to us, we are offering dual test. And when you are offering dual test, along with that, if you do the placental growth factor, and in the algorithm, you include the age of the patient, history, and other parameters, you will get a beautiful risk index. This is what I was talking about. Manipal module, I would call it. As you can see that Kasturba Hospital prescription that we always give. And here it is. They have already given us the report saying that it is for early preeclampsia, it is 1 in 1,000 or rather 10,000. And for late preeclampsia, 1 in 6,000 something. So what are the things that we do? Dichotomous markers, that is parity, whether she's primigravida or multigravida, race. Obviously in Manipal, there's only one race most of the time, but we do get some foreigners, some African students or their parents and things like that. Previous preeclampsia, the most important factor which we have already seen, and hypertension in herself. These are called dichotomous markers. We have to mention them. If we don't mention, if the PGs don't mention, the Department of Biochemistry promptly will send back the request, and they will say, we are not going to process this sample. So we are very, very particular that these things are mentioned. Blood pressure on the day you send the test. Biochemistry, what do we do? PAP-A, anyway, we are doing as a Down syndrome screening. Placental growth factor is the one extra thing that is done. And then, of course, ultrasound. You can actually do a uterine artery Doppler. It is little early for us at the time of when we are sending 12 to 14 weeks. Of course, it's not too early also. We can do it and later find out whether there is persistence of notch a little later. So this is what I was trying to tell you, that we are filling up all the necessary data. And then as you can see here, with this and with the ultrasound and with dichotomous markers, the report comes. As I told you, here I'm blowing up the same picture. They give us the risk factors for early preeclampsia less than 1 in 10,000. So we are reassured. And for late preeclampsia also, 1 in 6,838. Both are low risk. We have, of course, done a study on this. These are very highly reliable. So once this test tells us that it is low risk, most of the time they have been low risk only. So what are not useful? This is very important for us to know more than what is useful, because we will be wasting our time, our money, our energy. And these, some of the tests, if they come positive, patient is confused. You are confused. You don't know how to counsel the patient. So we need to know this, very important. Proactive biophysical tests, rather provocative biophysical tests, such as rollover test, as I told you, angiotensin 2 challenge test, and isometric exercise. That's what I was trying to tell you, this gripping test. Serum uric acid, waste of time, waste of money. Screening for inherited thrombophilias, it should be done only in research setup. There also it is hardly done. And APS in general population, out. Don't do this. It's not useful. So with that, I come to the part of prevention, and I leave it for tomorrow. Thank you very much.